May I request the next presenter, Dr. K. Aparna, to present her case on orbital dirofilariasis.
Good morning, good evening. I am Dr. Aparna KS. My topic is periorbital dirofilariasis, clinical profile and role of ultrasonography in its diagnosis. Orbital dirofilariasis is a zoonotic helminthic infection caused by the nematode Dirofilaria. The common human manifestations are pulmonary, subcutaneous, and ocular. Dogs are the primary host for this organism, and humans are the accidental host. It is transmitted to the humans by the bite of Culex, Anopheles, and Aedes mosquitoes. Ocular involvement can be subconjunctival, periorbital, anterior chamber, and even vitreous cavity. And today we will be dealing only with periorbital dirofilariasis. Due to its myriad of clinical presentations coupled with limited laboratory diagnostics and poorly represented imaging features, prevents an early diagnosis of this condition. So aims of my study are to describe the clinical profile and imaging findings of periorbital dirofilariasis and to describe the role of ultrasonography in confirming the diagnosis. This is a prospective study conducted over a period of 4 years in a tertiary eye care center in South India. We included 14 patients who are clinically suspicious, imaging suggested, and excision biopsy proven cases of periorbital dirofilariasis. After detailed history taking and comprehensive clinical examination, all the patients underwent orbital ultrasonography and MRI scanning was done. Excision biopsy was done to prove the diagnosis of dirofilariasis. Coming to the results and discussion, dirofilariasis is no longer a rare disease, especially in our part in South India. But most of the available literature describes individual case reports or small case series only. And there is a huge lacuna in literature regarding the imaging findings of ocular dirofilariasis. In our study, out of 14 patients, we had a female preponderance. Mean age of the population was 35.4 years. It was equal in between both eye and right eye and left eye. All cases it was unilateral, and there was a palpable mass in all the cases. It was more common in the superior medial quadrant followed by the inferior medial quadrant. This is an interesting case of a 37-year-old lady who is a known case of ALL who presented with a sac area mass which was mimicking a on MRI scanning, there was a hyperintense well-defined lesion in the subcutaneous plane. So it is mimicking an extramedullary deposit of ALL. This is another case of a 21-year-old girl who presented with on and off tender erythematous swelling mimicking a pharynculosis. These are two elderly gentlemen who presented with congestion, chemosis, mild proptosis and movement limitation mimicking orbital cellulitis or pseudotumor. So, we had cases mimicking orbital cellulitis, pseudotumor, pharyngeal or frontal mucosal, lacrimal sac mass, and orbital and adnexal tumors. So, periorbital dirofilariasis can be a great mimicker of various orbital swellings due to any etiology like infectious, inflammatory, or neoplastic conditions. CT scan showed heterogeneous soft tissue mass according to the literature without peripheral enhancement mimicking an abscess. In our series, CT was done only in 4 cases which showed the non-specific soft tissue swelling. Grovel et al. Described MRI findings in a single case. And according to them, T2 weighted image showed the inflammatory nodule as a thick wall semi-liquid structure. And on T1 weighted image, there was a central tubular structure that was representing the worm. Gopinath et al. Used the scan to exclude the deeper extension to know the plane and to exclude other conditions like pseudotumor or lacrimal gland involvement. In our study, MRI was done in all cases. All cases showed hyperintense soft tissue swelling, and the inflammatory nodule in T2 weighted image appeared as a thick wall structure in 6 patients only, and the central tubular structure was visible only in 3 cases. So, the role of CT or MRI scan is limited in the diagnosis of dirofilariasis. We did ultrasonography in all the patients. The USG findings in periorbital dirofilariasis have been reported in a very few case reports only. And what we got is a well-defined cystic swelling. You can see there is a cystic swelling in all these cases with a serpiginous mobile structure with parallel echogenic walls and anechoic lumen. That is like a tram track appearance. So this we got in all our 14 cases. During UST, we have to use high resolution ultrasonography. We have to be very gentle. Do not press over the mass because it can compress and the lesion may collapse, and we may not be able to get the finding of the central structure. We can use a gel pad also. Marie and Paul et al. Used UBM for the diagnosis of subcutaneous dirofilarial nodule, which showed a thick wall cyst, but they couldn't identify the presence of worm inside that with the help of UBM. Excision biopsy was done, and all the patients were treated with ivermectin 12 milligram. The histopathological examination showed cross sections of variably degenerated organism. 4 cases were dirofilaria repens, 1 tenuous, and 1 case of dirofilaria immitis. In remaining 8 cases, we couldn't find the species identification due to poor fixation, surgical artifacts, or poor tissue response. So to conclude, there is an increasing prevalence of dirofilariasis due to the changing epidemiological and environmental conditions. It is a great mimicker of orbital swelling due to various reasons. So we have to keep it as a differential diagnosis of orbital cellulitis, especially with an on and off pattern of presentation. Role of CT scan or MRI scan is limited, but USG has a potential role as it provides dynamic real-time imaging. These are my references. Thank you.
Now you advise treatment or this thing on all swelling.
Whenever there is a visible swelling, and clinically whenever it is suspicious, I'm sending USG because it is cost effective, and patients who are willing for MRI, I'll send for MRI.
Okay, what I am asking is, with these 14 cases are diagnosed histopathologically.
Yes, only histopathologically proven cases are
So
included.
all these cases surgical excision is mandatory.
According to literature, we have to remove the worm, but I have a set of patients who are not willing for surgery just for taking out a worm.
What
And
happens
they
to
are not
that?
convinced about the diagnosis also. So such patients, it is especially useful. With MRI, we cannot confirm the diagnosis. Especially my patients, 2 patients with a history of malignancy. So they were expecting malignancy. So from the regional cancer center, they referred the patients to our center to rule out secondaries. In such patients, we can confirm the diagnosis with this technique. So it will be useful, we can plan the surgery accordingly.
What I am confused is whether this gives you a message that everything should be excised. That is the only doubt I have.
Actually, we have to remove the worm. But with ivermectin, I have a set of patients that study is going on. With ivermectin, we are getting with the steroids, we are getting good results.
USG was done in one machine or multiple machines?
One we are sending to one radiologist.
Operator is one or multiple operator?
One operator.
Or you're not sure?
Yes, I did all the cases.
Ultrasound? Ultrasound?
No. Like I told about the surgery. One particular radiologist.
Okay.